there notes on it?
You have still got it, and yeah, immunization you can get, but I think Dr. Hunt has already put it in today. He was putting it in. Have a check in immunization if immunization is there. Okay? I gave it to him and he said that it will be there. Can you get it? He just put it on this morning, immunization and also MHC. I'm going to finish off MHC and then go on to immunization.
All right, thank
you. Okay. And I'll try and, get him to keep it updated. No, I don't want that one, but MSc genetics, and that's good. Yeah, good. Okay, good. So thank you. Okay, I guess it's still break? Okay. I'll give it a couple of minutes. That's okay, after 12 o'clock there's nothing until lunch. Okay. And I can see some people already are eating lunch, so there's no rush, right? Now, what I'll do is I'll finish off the MSc, just a tiny portion left, and then move on to immunization lecture. What we talked about was the genetics of the MSc, what the genes and what the loci are, and how the diversity or the polymorphism is generated. For class 1 and class 2 MSc antigens, and how they are inherited, and what is the role of the mixed lymphocyte reaction, in other words, alloantigen recognition, expansion of T cells, proliferation of T cells in response to class 2 MSc antigens, and induction and activation of cytotoxic cells, the cytokines that are generated during the process, and how it can damage the graft very, very quickly. Of course, later on there is, as the organ releases specific antigens, those are alloantigens and other antigens as well, MSc antigens and other antigens, they are not processed and presented to the host T cells in a normal manner, and there is induction of antibody response that in turn again will cause damage, either complement mediated that you've already learned from Dr. Mayer, as well as the ADC that both Dr. Mayer and Dr. McCallum have mentioned. So that is where we were. What I'm going to do is, one of the things that I did not tell you about was that, but you saw that, what is the nomenclature of the MSc antigens. And you will see something like A21 or A3, that refers to the polymorphic form. 3 refers to one of the polymorphic forms, and A refers to the locus. And in the case of D, P, DQ, and DR, it is the same nomenclature. the letters followed by a number. That was somewhat older nomenclature. With the molecular biology techniques that they are detecting actually the genes, what they do is it's designated by the letter followed by a 4-digit number. And first two digits are actually refer you back to the old nomenclature. So if you see A03 followed by 2 more numbers, A03 actually refers to the old nomenclature. That means the A3, third polymorphic form of A locus antigen. And then there is another 2-digit number that is actually referring to the sub-polymorphic forms. Actually, since they were serologically defined old ones, there are some other polymorphic forms as well within that group, and that is detected by PCR. Okay? So the new nomenclature is a 4-digit number. That's all you have got to bear in mind. And that is based on the PCR-based sequence of the locus. And of course, different individuals would have different sequences. That's what gives it antigenic uniqueness. So that's the system for nomenclature. Now, all right, depending on how the graft is rejected, how quickly, the temporal characteristic, as well as what the mechanisms are, these graft rejections you'll find in the book as well as in the notes are classified into 4 different categories. And they are the hyperacute rejection, which is within minutes. As a matter of fact, some extreme cases are the organ is transplanted, the blood vessels are anastomosed, and then within minutes there are signs of rejection, malfunction of the organ, and the actual the look of the organ can tell you that it is in the process of rejection, and that is referred to as hyperacute rejection. And the mechanism there is pre-existing antibodies. That's why it's very important to cross-match, that the recipient does not have any antibodies that can react to the donor's MHC. Otherwise, the antibodies will combine with the tissue, the complement will be activated, and there will be complement-mediated damage, and there will be inflammatory cells at the junction where the organ has been anastomosed, and damage that anastomosis and also damage the organ. So that is the hyperacute rejection, as I said, due to preformed antibodies. Then there is accelerated rejection, and that is due to pre-existing cytotoxic T cells. If there are not antibodies, you may have matched for the antibodies, but there may be pre-existing cytotoxic T cells or memory cells, and these are reactivated, of course. These are reactivated, and they produce their cytokines. Cytokines recruit the effector cells, and effector cells damage the organ. And it is within days after transplantation. And then there is a sort of acute rejection that is days to weeks. And that is that the patient did not have, it will occur in patients that do not have any preformed antibodies or presensitized cells. But as the organ, the foreign antigens stimulate the recipient's cells, immune cells, they are going to produce effector cells and effector molecules, namely antibodies, sensitized cells, and then cytotoxic cells. So that's de novo, that's a naive or the primary sensitization process. So it takes longer than what the time that will take for the presensitized cells to get reactivated. It's like a booster response. Remember Dr. Mayer told you an amnestic or secondary response in a context with antibodies? Well, there is secondary response to graft rejection as well. And that was the accelerated, but the primary response is seen in the acute response, acute rejection. And it is a lot longer than the accelerated rejection. And finally, there is chronic rejection. And that is, the mechanism is not really well known. It is multifactorial, really. The time frame here is months. The patient is okay, organ is functioning all right, and months later, there is a rejection episode. And this may be due to either cross-reactive antigens that have sensitized the individual because of certain infections, or it may be the damage to the organ which was responsible for dysfunction of that organ in the first place. Okay? So there is also a belief that organ as it exists in the body, because there's a large amounts of, it's a large tissue and large amounts of antigens that his immune system is exposed, and there is some induction of tolerance to the foreign antigens. And we'll talk about that later in the next not next lecture, but one after that, when we talk about tolerance. So the organ can actually induce tolerance in the body. And for some reason, that tolerance breaks down. Okay, you had a...
In hyperactive reaction, what's the chances of the recipient has antibody already to that MHC?
There are lots of chances. Well, in the hyperacute, the question is, you heard that, what are the chances of the recipient having antibodies? Well, multiple transfusions. Okay? In the case of women, multiparity. Okay? There are infectious agents, pathogens that can induce antibodies that can cross-react with the tissues and organs. And that is the reason it is always done that there is a cross-match between the donor and the recipient. The recipient is always checked for antibodies against the tissue antigens of the donor. Okay? Any other questions? So those are the 4 different modes of rejection that have been defined. Okay, what is most important is, of course, the health of the recipient as well as donor. You know, donors are both checked for, the recipient is checked for hypertension and any other routine, examination, physical examination. He should be in reasonable health. But after that, the cross-matching, ABO matching is important, and also matching of the HLA. When I was talking about polymorphism, I emphasized that it's very difficult to have a perfect match of the MHC, let alone other histocompatibility antigens. However, it has been found that there are certain matches are more crucial than the other one, and DR among them is at the top of the list. Okay? DR, okay. So the DR is the most important. As you can see, the survival is the highest. And after that, the more the matches, the better they are. A haploidentical sibling is often a good donor if there's a DR match. Nowadays, with the immunosuppressive agents, it is not unknown that totally mismatched organs are also transplanted, particularly when there is a desperate situation. Okay, so there are some transplant clinics, and that I became aware only about a couple of months ago. Somebody from New York was giving a talk, and he said they often take unmatched donors. That, of course, does give the recipient time if they are in dire need for a transplant. However, it is ideally one should have a DR and a B locus match, and or better than that is DR match with one haplo identity. Okay? What has been observed by empirical practice, and the mechanism for this effect is not really well understood or known, is that if the recipient is given small amounts of blood transfusion, 100 to 200 cc's, from the donor. Remember, they are matched for ABO, so there won't be transfusion reaction. That's most important, of course, to match that. But then after that, if the recipient of the organ receives 2-3 doses of 100 to 200 ml donor blood transfusion, donor type blood transfusion from the donor, the grafts work much better. So that has been sort of discovery from the practice itself, and it is practice. Okay? What the cause are, people have sort of hypothesized that there is induction of some sort of tolerance or hyporesponsiveness against the donor tissues. And that is the reason that the recipients, those who have received transfusion, okay, do better. This yellow line, okay? Now, all done, there will be not a hope for the organ to survive even with the best matches, because not just MHC, there are other antigens as well, I told you about. So immunosuppressive agents are a must. Initially larger doses, and that is tailed off to maintenance doses. And what are the immunosuppressive agents? I've got a list of them here as well as on your handout. And what I expect you to do is remember the agents and what their mechanism of action is also. Okay? Most importantly, corticosteroids are used to reduce inflammation. They are anti-inflammatory. They alter T cell and PMN traffic. So by diverting them from the site of inflammation, it can reduce the chances of damage to the graft. Cyclosporin and tacrolimus, those are the two most popular immunosuppressive agents. And there's a third one I'll talk about that is in the same category. And these three work via the IL-2 pathway. Tacrolimus and cyclosporin, they inhibit the production of IL-2 cytokine. And remember, IL-2 cytokine is one of the most important ones that causes proliferation of the clones that are reactive clones. So they can inhibit production of IL-2 production by T cells in response to alloantigens or other antigens. IL-2, if you remember, Dr. McCallop told you just a few days ago, it also is needed for the differentiation of cytotoxic T cells. It also is needed for the activation of NK cells and a variety of other functions that this cytokine has. Okay. The third one is rapamycin, which is similar to tacrolimus and cyclosporin, but its mode of action is slightly different. It prevents activation of cells by IL-2. If you remember, IL-2 binds to this receptor, IL-2 receptor, and stimulates the cells, activates the cells to go into proliferation and also activation. Okay? So there's a very slight difference between the mechanism of action of these two and rapamycin. The first two, tacrolimus and cyclosporin, they suppress the signal induced by the antigen to synthesize IL-2, whereas the third one, rapamycin, it prevents activation signal by IL-2 via the IL-2 receptor. Okay? Now, the other few that are used is azathioprine, and it's a purine metabolism pathway it interferes with. Methotrexate, it interferes with folate metabolism. They're all immunosuppressive. Cyclophosphamide and melphalan, those are alkylating agents that can alkylate DNA, cross-link DNA, and therefore cells that are going into mitosis in response to antigen, like MLR in the case of transplantation, or activation by antigen, the DNA, if the DNA and RNA are cross-linked, obviously the cell is not going to go anywhere and it is going to die. Extremely toxic. There are other problems with the use of cyclophosphamide and melphalan, and their use is reducing now. However, they are still used in some transplant cases as well as autoimmune diseases. X-ray radiation is very, very non-specific again, and immunosuppressive agent, and it causes damage to all the mitotic cells. Therefore, it would result in lymphopenia in terms of immune system, but also causes damage to other cells. And it is used only in the case of bone marrow transplantation. And because it is used to reduce the malignant cell, the leukemic cell burden in the host, in the recipient. In addition to that, there are some others listed in your handout. Anti-lymphocyte serum, that is still being used. This use started in the 60s, and some centers are still using anti-lymphocyte serum. It's referred to as anti-lymphocyte serum, but it is a serum raised against T lymphocytes, and it reduces the number of T cells in a sort of non-specific way, and reduction in those T cells results in prolongation of graft. There are some other monoclonal antibodies that are much more specific to T cells, like anti-CD3 or anti-CD4 antibodies are also being used. There is an antibody that is often used in conjunction with cyclosporin, is anti-CD25. Now, CD25 is actually a part of the IL-2 receptor. So if you can eliminate cells that have IL-2 on them and with IL-2 receptor on them, obviously that will dampen the immune response and prolong the graft. Okay? And those agents are listed in your handout. Okay. In the bone marrow graft system, what is the problem? It's not the acceptance of graft, right? Remember, where is bone marrow graft used? Either in leukemias or in immunodeficiency cases, where there's general immunodeficiency. So what will happen? Would the host reject the bone marrow if there's incompatibility? No. What would be the problem? Say it louder, please, so that... Okay, it won't make T cells. Any other?
The donor T cells could react to it.
That's the most important reason. It is the complication. There is a complication. human bone marrow has got lots of mature T cells. In addition to the precursors, it has all sorts of T cells, mature T cells. And those mature T cells, of course, will recognize the alloantigen. The CD4 cells will recognize class 2. CD8 cells will recognize class 1. They will proliferate, and the cytotoxic T cells would be activated, and they are going to cause damage to the host. And what is the name of that syndrome? Graft versus host disease, GVH. Okay, and you saw some complications like erythema, like gut mucosal cells are destroyed. Okay, so graft versus host disease is the most relevant complication. So it is important to monitor and remove those cells that are going to cause graft versus host disease. And how it can be done is by treating them either with antibodies against T cells and complement and lysing them, and then removing the dead cells, because dead cells themselves cause problems when they are infused into the patient. That's one way that used to be there. There's a neat way now that is being practiced, and that is removal of them by a magnetic system. And there is a machine that's based on magnetic system. And what one does is, in this case, I'll go over this, and then if there's a problem, I'll address that. One takes the donor lymphocytes, the donor bone marrow cells, that contains T cells as well as other cells, and assuming that the T cells are these little yellow crescent with the blue nucleus, the antibodies will bind to them. They are antibodies that are specific for T cells, and these antibodies are tagged with magnetic molecules, like iron. Okay? So these antibodies, as you can see, they've got a little asterisk there, and those are little magnetic particles, and they are chemically coupled to the antibodies, and when you mix it with the bone marrow cells, they will combine with the T cells, of course. And if that mixture of antibodies and T cell and cells is passed on to a magnet now, all the cells that have that antibody, meaning the T cells, will stick to the magnet, and what comes out of there is cells, bone marrow cells that are depleted of T cells. Okay? And that technology is being used for other purposes as well, research as well as clinical purposes, to remove a variety of cells against which you can raise antibodies, and those antibodies can be coupled to magnetic particles. Okay? So this is being used. In your book, in your POPS exercise, you will see something that there is an advantage in not removing all T cells. And what is done is that one removes most of the T cells, but spikes them with some T cells so that they can stay there. And what is known is that in one particular case, this is practiced, is leukemias. In leukemias, it is of some advantage. By practice, it has been observed that it is an advantage to have a low-degree graft versus host-like reaction, and it is referred to as graft versus leukemia reaction. So you'll find that in your POPS exercise, and I'm just explaining it to you so that you know when you read it. Okay? So one can remove all of them, but it is advantageous in the case of leukemia to leave a few behind, or after removing to add back a few for graft versus leukemia effect. But if it were for treating an immunodeficiency, it is advantageous to remove all of it, because there you do not need any graft versus host reaction. Okay. Now, lastly, I told you that MHC is very important in certain diseases. Different people are susceptible or resistant to different infection to different degrees based on their MHC makeup. They've got a whole package of MHC antigens, obviously, 6 of the, in a heterozygous, completely heterozygous individual, 6 of the polymorphic forms of class 1 antigens, and then another 6 to 8 or 10 polymorphic forms of class 2 MHC antigens. And those MHCs find one or other peptide to incorporate into them, and the more peptides they can incorporate, obviously the more resistant the person will be. So there is a genetic basis for resistance based on MHC. Also, certain MHC-bearing individuals are more at risk of certain autoimmune and inflammatory diseases. And the table in your handout just gives an example of a few of them. That does not mean that everybody who has got a B27 is going to come down with ankylosing spondylitis or Reiter syndrome. No. What it means is, given other circumstances, they're at a higher risk for developing Reiter syndrome or ankylosing spondylitis. And the same thing applies to other, okay? There is in the list you'll find in the book's longer list, and diabetes is included among them and some other disease. Okay? That was all of for I had to say about MHC. I'll be happy to answer any questions while I change the topic. Yes?
Where do mature T cells come from in the bone marrow?
Okay, where do those mature T cells come from bone marrow? That's the question. As the T cells circulate, normally they do go to lymphoid organs, secondary lymphoid organs, but some of them do end up in the bone marrow. The bone marrow is in humans particularly, okay, bone marrow has got a lot of T cells from circulation. They go and localize in the bone marrow. Of course, mature B cells also, not relevant for this topic, but also go into, and it has been shown that the long-term antibody production after immunization is based on mature B cells having gone into the bone marrow and residing there. No, there's no need for removing mature B cells. It's really mostly, if you do not have any reactive T cells, CD4-bearing T cells, you're not going to develop much further in terms of either interacting with B cells to produce antibodies or cytotoxic T cells or NK cells or activating other cells. Okay? Any other questions? Yes?
You stopped your slideshow, but in our version of slides,
those I have blocked because those are not being used in clinical practice now. Dr. Hunt probably forgot to block it. Okay? I have on purpose because A, save time, B, those laboratory techniques that are being described there are not used, except the serology, the complement and antibodies and complement, monoclonal antibodies and complement for tissue typing. And the mechanism I did not want to go through in detail. Okay? Any other questions and comments? I'll ask Dr. Hunt to remove those from that. Okay? All right. If there are no other questions, I'll move on to the next topic, immunization. And what I'm going to cover is give you a little bit of historical background on development of vaccines and some background on history of development of vaccines, and then talk about what are different ways an individual can get immunized, and what is the nature of vaccines, and what the complications can be. Well, very quickly, Immunization has been around for a long, long time. And the earliest historical records show 3000 BC among the Chinese as well as the Egyptian civilization, they used smallpox. The smallpox had been around for a long time until it got eradicated, and they used crusts either as a snuff or other ways of introducing into the body. And then China, as I said, sniffing crusts of smallpox pustules dried up. It had immunizing effect. That was the way to vaccinate. Why do you think the custom of visiting the sick came into practice? Okay? One of the reasons is that when children and the families visit the sick, if it is an infectious disease, they get exposed to the organism and they get some benefit from it. 1500 BC, Turks introduced variolation. In other words, taking the smallpox crusts themselves, grinding it, and injecting into other individuals the actual pathogen without altering it. Of course, they did get mild cases of smallpox, but subsequently they were immune to it. And in 1700 AD, of course, there is the introduction of that variolation in the United States, as well as first UK and then US, taking the crust of actual smallpox and injecting. And to give you a little background on that introduction of variolation, this is recorded as the wife of British ambassador in Turkey in March 1777 wrote a letter home following the variolation of her son in Turkey, I think she was in, to a friend in England. The smallpox is so fatal, so general amongst us, is entirely harmless here by the invention of ingrafting. That's what she referred to, the injection of pustules, ground up pustules. I am a patriot enough to bring this invention into fashion in England. And following that, it was important. What was done is the crusts were injected into some prisoners with the promise that if they survive, their death sentences will be abolished and they will be forgiven from that. And lo and behold, it was effective. Okay? And they got double benefit from that. They got immunized against smallpox as well as their death sentences were withdrawn. Okay? Then the real experimental work in the smallpox vaccine was done, of course, by Jenner, who observed that dairy workers who were exposed to cowpox virus, and they got pustules very similar to smallpox, but not as severe and fatal, were subsequently immune to smallpox. And he took out that, and if I'm not wrong, he used it on his own son first. Okay? Hey, scientists are crazy. Even today, Dr. Mayer and I came across some people who were injecting endotoxin into humans for experimental work. Of course, there was consent for it. So that's not so unusual. There are a number of cases in history where people have used pathogens either themselves to test some hypothesis or some other close relatives. Anyway, and here's a picture of Sir Edward Jenner's, and here is the cow from which the pustules are being withdrawn. And then subsequently, of course, they will be processed to be used as a vaccine. Vacca, vaccine comes from the word vacca, means actually cow. Okay? So The original vaccine did come from the cow, and here's some painter's depiction of mass immunization by the physician. Okay, the modern era of vaccination and immunization started in the late 19th century. First vaccine was rabies vaccine, utilized at developed at Pasteur Institute. 1920s, a number of years later, several decades later, diphtheria and tetanus were formulated and used and still being used. Pertussis vaccine came along in 1934, and Salk vaccine, which is the killed poliovirus vaccine, was developed in 1955. 1960s, mumps, measles, and rubella vaccines were synthesized or formulated, and then Sabin live polio vaccine was developed also in the same year. 80s, Haemophilus, and 90s, hepatitis and varicella, and we are continuing to develop more and more vaccine. And it doesn't take much to look at the effectiveness of vaccination. Diphtheria, almost unheard of in this country. There were, several years ago, 1 or 2 cases in Russia. Pertussis, way down, several logs, orders of magnitude down. Tetanus, very rare. Haemophilus, only a few years ago there were cases, that was a major killer of infants. Haemophilus influenzae. Polio, almost unheard of now. Mumps, very far reduced, and you can see rubella and measles following the same trend. So vaccination has really been effective. What we tend to do is ignore the positive aspect of it. What we say, well, there's no pertussis cases, no Haemophilus cases, no smallpox, or smallpox is a unique agent by itself. But there are very few cases of these diseases, but there are so many complications of vaccine. And if you go on internet and search for vaccine and immunization, you will find there are people, sane people with intelligence. They are promoting, do not vaccinate. It's dangerous. It leads to malignancies. It leads to neurological problems. It leads to all sorts of problems. And it is not healthy to vaccinate. It will be your job to convince your patients, really, that it is very important to immunize children. There are many ways we can be immunized. I told you about visiting sick people. And there are different terminologies depending on how they are immunized. One can be immunized passively, first of all. Okay, we'll not talk about natural resistance. Dr. Mayer talked about non-specific immunity and natural resistance, okay? We'll only talk about immunity that we acquire, or adaptive immunity. It can be acquired passively. How's that? Well, if I go to the hospital and there are all sorts of pathogens around there, I may inhale some of them, I may touch some of them, I may ingest some of them inadvertently, and a subclinical infection will occur without any symptoms or very mild symptoms, and I will produce an immune response. I'm sorry, I'm totally somewhere else. Okay? Passive immunization we're talking about. Forget about what I said so far. Please, jury, please ignore that as if it is possible. Okay, forget that. Passive immunization. The best example of passive immunization is a child born. When a child is born, it has all the antibodies that the mother had. Okay? That's the best example of. And Dr. Mayer told you about why IgG, certain classes of IgG are very, very significantly important, and because they can cross placenta. and immunized. So first few months, the baby has got all the antibodies. The baby did not have to do any work. His lymphocytes did not have to be activated, did not do anything to acquire that immunity. That's why it's known as passive. So that's one passive immunization. And then there's active immunization. Vaccines are one example of that. And what I now will go back to, me visiting the hospital and then inhaling some organisms and ingesting some organism, coming in contact with them, and then producing antibody. I was not immunized, but I was, the immunity didn't come by itself. My immune system had to work for it in response to that exposure to the antigen. Now, passively, one can immunize by artificial means or the natural means. And the natural, I already gave you the example of natural across placenta. But the artificial is practiced very much in the cases where there is a dire need to protect a person who has been exposed to an infection. Example is rabies. Rabies is one example among the infectious agents. And then there are insect or venomous snake bites, where there is a need for immediately protecting the individual. And in this case, antibodies are used to inject into that exposed person. Another example is, of course, tetanus. Okay? If you will see in your POPS exercise on Wednesday that if a person has not been immunized for over 5 years or over 10 years, okay, more so over 10 years, depending on the depth of the wound and all sorts of conditions that you will learn about, that person has to be given, first thing they have got to be given is passive immunization. That's why if you are in an accident or you have got any deep cuts or lacerations, you go to emergency room, the first thing they ask, when were you given last tetanus shot? Depending on how long ago it had been, you're going to get passive immunization with preformed antibodies. In the case of tetanus, one uses human immunoglobulin, pooled human immunoglobulin from hyperimmune individuals, donors. In the case of snake venom, there are not many humans that are immune to snake venom, and so one has to resort to antibodies produced in horses. So horse anti-venom immunoglobulins. In the old days, actually, they used tetanus immunoglobulin as well from horses, but there are complications with that, and we'll talk about that in the POPS exercise. You will see those complications, and also we'll talk about when we come to hypersensitivity lecture. Good idea. Good question. If the child gets all the immunoglobulins from the mother, why do they advocate breastfeeding and claim that breastfeeding is good for the immunization? If you remember, which immunoglobulin class crosses placenta? IgG. And which immunoglobulin class is in secretions? IgA. Okay? So by that transplacentally, the child is not going to get any IgA. Now, why should it be important? What are the diseases that children get most? Diarrhea, okay, GI tract infection, pulmonary, secretory, open organs, okay? So that is one of the reasons. And IgA survives the gut environment, all the enzymes that are there and low pH. So it can traverse from the stomach to the GI tract and that way confer immunity against those pathogens against which the antibodies are in the milk. Okay? Yes.
They just start to wear off for a little while?
Of course, they remember that do they start to wear off, that passive immunity? Yes, of course, it will wear off, because remember that Dr. Mayer, when he presented a table there, he told you not to memorize, and I'm not asking you to memorize that table. Don't get me wrong. But there is different half-lives of different immunoglobulins. So as the mother, when we come to immunodeficiency, I'll show you how it declines. But mother's immunoglobulin, 100% of child's immunoglobulin is mother's at birth. But with time, it will decline, and its own immune system will be stimulated by exposure to different environmental agents and produce its own immunoglobulins. Okay? So, now, active immunization, of course, is by either exposure, okay, or by vaccination. And those are so natural will be by active immunization by, as we inhale, as we visit sick people, as we are exposed to environment where those pathogens are, we get immunized. Okay? Physicians get immunized to an awful lot of pathogens because they are among sick people all the time. Okay? So their antibody titers are probably higher than anybody else in the population to certain pathogens. Okay? And that is the natural immunization. And artificial immunization is all the vaccines that we are using nowadays. Okay? I will stop here and then continue tomorrow. And I'm here if there are any questions.
I just wanted to thank you. It's so interesting. And it's neat when you can hear something that actually parallels to things that people are talking about in the news. Or
Yeah. I'll try that. Yeah, I'll try that. But you know, it is amazing how many people I didn't tell the accent. Somebody called me and said, "Well, I went to mother went to